Welcome to the MD Edge Daily News for Thursday, August 2nd. I'm Nick Andrews.
And I'm Mary Ellen Schneider. Today, who are high-need, high-cost patients?
Also today, seroconversion is not associated with sustained drug-free remission in RA.
And later, a new myeloma frailty index predicts survival based on biologic age.
But we begin today with CMS Regulatory Targets in 2019. Doctors could see changes in how they are paid for the drugs they administer in their offices, depending on the outcome of two recent regulatory actions proposed by the Centers for Medicare and Medicaid Services. The more immediate action could see an alteration to payment rates for newly launched drugs. The more long-term action could be the relaunch of the Competitive Acquisition Program. However, there is much more uncertainty surrounding that change. CMS is seeking to lower the Part B add-on payment for drugs that are new to the market and do not yet have an established average sales price. The proposal calls for these drugs to be reimbursed at the wholesale acquisition cost plus 3% rather than the current rate of plus 6%. The change is part of the proposed physician fee schedule for 2019. Some organizations took issue with the proposal. The American College of Rheumatology says that the plans to cut add-on payments for new drugs could slow market uptake of biosimilars and thwart the administration's effort to reduce drug prices. And the Community Oncology Alliance says that they believe this payment cut for new cancer therapies will result in drug manufacturers actually increasing wholesale acquisition cost list price so that their new products will not be at a competitive disadvantage. The second proposal, which could take longer to materialize, revolves around the potential relaunch of the failed competitive acquisition program for Part B drugs. CMS is currently requesting information with questions on what a revamped program could look like if the agency were to move forward with it. The request for information is part of the proposed rule updating the outpatient prospective payment system for 2019.
Among patients who are hospitalized with gastrointestinal and liver diseases, a clearly identifiable subset of these patients uses significantly more healthcare resources and incurs significantly greater costs. This is according to the results of a national database analysis published in Clinical Gastroenterology and Hepatology. These high-need, high-cost patients are significantly more likely to be enrolled in Medicare or Medicaid. They are also more likely to have lower income, to be initially admitted to a large rural hospital, to have multiple comorbidities, to be obese, or to be hospitalized for infection. The researchers note that gastrointestinal and liver diseases incur more than $100 billion in healthcare expenses annually in the United States. Of that $100 billion, more than 60% is related to inpatient care. Researchers used the nationwide readmissions database to investigate patients with inflammatory bowel disease, chronic liver disease, functional gastrointestinal disorders, gastrointestinal hemorrhage, or pancreatic diseases. They report that the most common reason for hospitalization is chronic liver disease, followed by functional gastrointestinal disorders, with IBD being the least common reason. Patients in the highest decile spend a median of about 4.5 days in the hospital each month. In this subset of patients, the costs of each hospitalization ranged between $7,000 and $12,000 per month. Researchers say that interventions may include better access to care and connectivity between rural and specialty hospitals.
In patients with seropositive rheumatoid arthritis, seroconversion within the first year of treatment is not associated with long-term sustained drug-free remission. This is according to results of a randomized treat-to-target study of patients with early RA. Researchers note that previous studies found no association with remission or radiographic damage. In the current study, researchers investigated the association between seroconversion and SDFR and found no association. They included nearly 400 patients with early RA from the IMPROVED trial who were treated with methotrexate and high-dose prednisone. At 12 months, 6 of the 170 patients had seroconverted all autoantibodies to negative, and only 2 of those 6 patients had achieved SDFR. Meanwhile, 19 of the 194 seropositive patients achieved SDFR without seroconversion. And neither the proportion of autoantibodies converted to negative nor relative decreases in autoantibody levels were associated with SDFR. Emma de Mol is a researcher in the Department of Rheumatology at the Leiden University Medical Center in the Netherlands. She says that future studies are needed to identify whether other immunological parameters, such as the number of phenotype or circulating autocorrected B or T cells, might be a better reflection of the disease persistence and markers for immunological remission.
And finally today, a new frailty index predicts survival in older patients with multiple myeloma based on accumulation of aging-associated deficits rather than chronological age alone. A 16% increased risk of death was seen for each 10% increase in the deficit accumulation frailty index. The index includes 25 variables related to health function and activities of daily living. This is according to research published in JCO Clinical Cancer Informatics. The researchers also report that there was a weak correlation between chronological age and increase in deficits tracked by the index. Dr. Tanya Wilds is an assistant professor in the oncology division at Washington University in St. Louis. She says that these findings demonstrate that chronological age alone is not a good measure for assessing overall health in patients with multiple myeloma. There are existing tools to assess frailty. One is an index proposed by the International Myeloma Working Group that looks at age and other indexes related to comorbidities. There is also the Revised Myeloma Comorbidity Index that incorporates age with other prognostic factors. Dr. Wild says that although both of these tools provide prognostic information, chronological age automatically increases frailty without taking biologic or functional age into account. By contrast, the new index is based on the concept of biologic age, in which the health status of an individual is measured based on the proportion of aging-associated deficits they have accumulated. In this study, researchers applied the index to 305 patients with newly diagnosed myeloma who were at least 66 years old and who had completed the survey within 1 year of diagnosis. They report that the index classified more than half of the patients as frail. For those patients, the median overall survival was nearly 27 months, compared with more than 43 months in patients that the index classified as not frail. And that concludes the Thursday edition of the Daily News. You can find links to these stories in the podcast description. For MD Edge, I'm Mary Ellen Schneider.
And I'm Nick Andrews. The Daily News is published every weekday at 4 a.m. You can make us a part of your routine. Subscribe today, wherever podcasts are found.